Bismillahirrahmanirrahim. So today's presentation is about a rare genetic neuromuscular condition and the approach and treatment options that we have available for those genetic neuromuscular conditions. So the outline for today's presentation is the case, followed by some discussion about the myopathic disorders and approach to genetic myopathies, and especially with focus on Pompe disease and the treatment options. We're going to a little bit discuss about the genetics involved and some discussion about the case. So the reason for consultation that we usually have in our neuromuscular clinic many times is high creatine phosphokinase levels or CK levels. This is not uncommon that general physicians and neurologists come across this question and they end up referring these patients to neuromuscular clinic for further evaluation. I personally like these patients because it takes some brainstorming, some evaluation, and some high-end neuromuscular stuff. So let's start with the case for today. And that case I'm going to present is one of my patients who presented with backache in 2007. She had an epidural injection for cesarean section without any radiation or pain in her legs. Her liver function enzymes were noted to be higher in 2007. For unclear reasons, she was diagnosed with fatty liver. Then she had a fall in 2014 while going upstairs, resulting in ankle fracture. She was using cane for the past 6 months because of the difficulty in mobility, especially for longer distances. She noticed some shortness of breath since 2019, especially on exertion. She also noticed some shortness of breath while laying in bed and it improves by laying on the left side. And I think that is a very important clue in the history. Sometimes she has to stop while walking and take some rest, and then she gets better and able to walk again. It is some component of fatigability. And when I asked her if she's gonna go to garage to her car, she said she may stop 2 times before she actually get to the garage. She mentioned no change in the urine color, especially after exercise since teenage years. She mentioned no physical limitation growing up during teenage years, and no particular birth or developmental history. All these points actually lay the ground for the further discussion and evaluation for these patients. In brief, when I ask a patient going upstairs is harder or downstairs, so if this patient is having more proximal weakness, hip weakness, then there is difficulty going upstairs. If there is, as a general rule, difficulty going downstairs, then these patients may be having neuropathy and difficulty perceiving or having that proprioceptive sensory loss. If a patient is having difficulty laying in bed, it could be for pulmonary reasons, but it could be because of the diaphragm as well. And also the change in the urine color is important, and the history or the developmental history is important because those can give us a clue about what we need to do in terms of the workup. She mentioned that she was noted to have bigger calves and also have calf spasms, and she noticed some improvement with Lyrica, but again, this was her personal perception. She mentioned no difficulty in approaching objects on the shelf or brushing her teeth, which also goes with the proximal upper extremity weakness. There was no difficulty writing, so no upper extremity symptoms in her case. There was no history of bladder dysfunction. She noticed some ongoing swallowing difficulty, even to liquids for past 1 year. So there was some progression of the disease, despite it was slow, involving some bulbar component as well. Her brother had the diagnosis of blood cancer. Her grandfather had history of pancreatic cancer. There was some history of rheumatoid arthritis in grandmother. Also, her mom had history of lupus and fibromyalgia. She had 2 kids, and one of the kids has ACL surgery and calf spasms. She had the past medical history of hypertension, Hashimoto's thyroiditis, anxiety disorder, and restless leg syndrome. On examination, she was obese with a BMI close to 36 and also had a scar in the left thigh and ankle because of her recent surgery. On a motor strength examination, she was having predominant proximal lower extremity weakness. So upper extremity strength exam was normal. Again, that is comparative exam. It's not you try to compare with yourself, but you try to compare one side of the patient to the other side and also see patient is able to do on the standard strength exam. So she was having more proximal lower extremity weakness compared to distal. She was having some Welling gait with negative Trendelenburg sign, which comes with hip abductor weakness. Also, there was loss of sacral dimples and lumbar lordosis, which kind of goes along with some kind of decompensation in terms of her skeletal or musculoskeletal weakness. Difficulty getting up from the chair without support. Again, this could be because of many reasons, but it could also goes towards or point towards proximal hip weakness. She was walking with a cane and no scapular ringing or spinal deformity otherwise on clinical assessment. She had a detailed workup, which is another part of as a consultant, you have to go through the prior workup to understand the case better. Many times it's just maybe some key piece of information is missing, and you can get that piece, put it in the whole pieces of the puzzle, and try to find out what it is exactly. So her workup was negative for the complete blood count. Most of the antibodies were negative as well. Cryoglobulin, lactic acid levels were normal. Vitamin B12 was normal, but the abnormal ones are highlighted in yellow. So her comprehensive metabolic profile was consistent with raised liver enzymes, as we hear that in the history as well. Her CK reading there was no single normal reading, and the highest was 1103. Serum aldolase was high as well, but only once. ESR was a little bit higher. C-reactive protein was a tiny bit higher. ANA was positive, a speckled pattern. She also had TSH, which was noted to be very high in the past. And along the same line, her thyroid peroxidase antibodies and thyroglobulin antibodies were positive, consistent with the thyroid autoimmune disorder. As we know from the past medical history, she has history of Hashimoto's thyroiditis. On prior other part of the workup that she has, the muscle-specific kinase antibody, acetylcholine receptor antibodies for myasthenia gravis was negative, Lyme serology was negative. So most of the test was negative, but she did have high or mildly high liver enzymes, beside high CPK. So she had a prior nerve conduction study, which was consistent with, again, degeneration changes, which were acute degeneration changes in the proximal muscles compared to the distal muscle. Again, there were no changes in the lumbar paraspinal muscle, so it doesn't point towards radiculopathy and actually points more towards proximal muscle problem. She had the nerve and muscle biopsy, which reported with extensive type 1 fiber atrophy and markedly increased central lying nuclei, extensive myofiber degeneration or necrosis as seen in rhabdomyolysis, and sural biopsy with multifocal loss of unmyelinated fibers. So this was her genetic test. If you see, so she has the GAA, we're going to talk about that later on, was heterozygous positive, but consistent with pathogenic mutation. ITGA was another autosomal recessive muscular dystrophy gene, which was likely pathogenic, but then she had a couple of variants of uncertain significance, which I'm going to talk about. So two pathogenic variants were identified. Those were associated with autosomal recessive Pompe disease, one likely pathogenic variant identified in ITGA, which, as we discussed, is consistent with autosomal recessive congenital muscular dystrophy. But for autosomal recessive disorders, there has to be both copies of genes should be mutated to give you that pathology. But in her case, it was heterozygous mutation, not homozygous mutation. So question to ponder upon at this point were, how high CPK is really high? Does this patient has Pompe disease? Now coming to the CPK, usually as what we call rhabdomyolysis, in that case, the CPK has to be more than 2,000. As a neuromuscular specialist, what really rings a bell to make us feel that it is really pathological, abnormal, in that case, the CPK should be more than 1,000. If it's lagging below 1,000, there could be many other reasons, including simple exercise, minimal physical injury, trauma. Even a needle stick injury can give you high CPK levels. So be careful about that. So history is very important before you actually get to the laboratory testing and confirm what's going on and is it really pathological. Now, coming to the part about does this patient has Pompe disease that we're going to discuss in the later part of this presentation, how to decipher this case. Coming to metabolic myopathies, those are disorders of skeletal muscle substrate oxidation. They are primarily divided into three further types. What we call is glycogen storage disorder, fatty acid metabolism disorder, and mitochondrial myopathies. Then there are pseudometabolic disorders or pseudometabolic myopathies. Those are important to understand because if a patient is having some other clues, those could be helpful. But it's important to recognize and differentiate between the metabolic and pseudometabolic myopathies. So the pseudometabolic ones could be because of the structural or calcium dysregulation, what we call the channelopathies, and myotonic dystrophy is included in those disorders. Limb-girdle muscular dystrophies are more of structural disorders. The clinical clue to these pseudometabolic disorder is that there is a persistence of high CK levels beyond rhabdomyolysis. So it usually stays in thousands, despite the patient is not in rhabdomyolysis or acute crisis. Then another important group of disorders we need to understand, and that is acquired metabolic disorders, which could be because of the medication, like statin can give you myalgias, rhabdomyolysis, and if a patient is having mild metabolic myopathy, it can precipitate those patients when it is started in patient with a metabolic disorder. 10% of the patients on statin do complain about myalgias. Additionally, patients who are having vitamin D deficiency can precipitate again mild metabolic myopathy, and it can present like metabolic myopathy with mildly high CPK levels. Hypothyroidism and hyperthyroidism could be other disorders which are acquired, could be autoimmune, could be surgery related or iatrogenic, and can give rise to clinical pattern consistent with metabolic myopathy. So these need to be differentiated. And like the case we discussed, the patient was already diagnosed with Hashimoto's thyroiditis. The clinical manifestations of metabolic myopathies include neonatal hypotonia, hypoglycemia, and encephalopathy. This is usual manifestation in neonatal patient population. And more importantly, in the adult population, that what I see more, they present with exercise intolerance, which could be pain and cramps, rhabdomyolysis, and either slowly progressive weakness or fixed weakness. Now, coming to the part with glycogen storage disorders, cramps and myalgia are more common. When the cramp is highlighted in this slide, because these patients tend to manifest more with cramp, which is more sustained, painful kind of sensation compared to the low degree of soreness. And it comes up with short duration, high intensity exercise. It could be sprinting, it could be something you are not doing routinely, and all of a sudden you have to do that physical activity, which is high intensity, and it can precipitate the event. These patients do have or can have potentially gout manifestation and hyperuricemia in 25% of the cases. There could be second wind phenomena, which is exactly these patients, they have some exercise intolerance. So after some time, they have to rest and then they start again. So this phenomena actually keep them going, and it takes longer to present to physician to get evaluated, because if there's an exercise intolerance to the point that they are not able to perform, they will present to physician early on. But because of the second wind phenomena, these patients tend to present late in the neuromuscular clinic or to come to the attention of their primary doctor. There could be fixed weakness. These patients additionally can have ptosis, retinal dystrophy. High carbohydrate meals actually help if you take it before the activity. Forearm non-ischemic exercise test with no lactate and high ammonia rise. So the exercise test can be done as an ischemic or non-ischemic. The ischemic is out of favor because of precipitating rhabdomyolysis in the patients. So non-ischemic test is more favored, and it has to be performed appropriately. Otherwise, there will be inconsistent result, and that will actually not helpful. But I think as a screening tool, this could be helpful to differentiate about a true metabolic disorder or not a metabolic myopathic disorder. But in glycogen storage diseases or disorders, there is a no lactate peak, which we usually see with mitochondrial disorder, but there is a disproportionate high ammonia rise noticed in these patients. Just to mention, even with a normal test in a normal person, patients tend to have mildly high ammonia and slight high lactate, especially with the ischemic test. But again, that should not be beyond 3 times the normal value. Muscle biopsy with and without high glycogen globules are noted in these patients. So again, could be confusing because there could be high glycogen storage noted on the stains, or it may not be noted. But finally, genetic testing is something which could be very helpful in these patients, and sometimes even that is confusing as well, like the case we just discussed. So in fatty acid oxidation disorders, these patients also tend to have myalgia with high endurance exercises. So it's not a short duration, high intensity, it's a long duration, like a marathon race. They present with a low degree of soreness, which kind of continues on. But additionally, if these patients have some superimposed illness or fasting, then they can land into rhabdomyolysis, which we should be very mindful of, but at the same time can also bring these patients to clinical attention. They do have high CK levels. There could be hyperkalemia and hypoglycemia. In these patients, as part of the workup, we can do acyl-carnitine profile, urine organic acid, but those are screening tools, and if still not clear, then genetic testing can be done in these patients. Coming to mitochondrial disorder, which is the third group of metabolic myopathic disorders. So again, these patients also have myalgia. They may notice some shortness of breath with long duration endurance activity, rhabdomyolysis with superimposed illness or fasting. But more importantly, these patients have multisystemic involvement, especially gastrointestinal. So they may have vomiting or some nausea with exercise coming up. Lactate levels are noted to be higher in the regular blood test, but again, exercise stress test will give us high respiratory exchange ratio, which means that the oxygen levels between the arterial and the venous blood not going to have the normal ratio, because the cells won't take up that oxygen from the arterial blood. So the difference between the arterial and venous blood oxygen concentration are going to be very different, which points towards that the cells are not taking up oxygen, or mitochondria, which is the respiratory chain involvement, and the energy production house in the body is not working appropriately. In muscle biopsy, Gomri trichome stain or genetic testing could be another thing which can be done in muscle biopsy. So it's not only the genetic testing on the blood, it is the genetic testing on the muscle sample. Additionally, enzymatic analysis can be done. These patients are actually very, very confusing, very few, but at the same time, much more tougher to diagnose. They can have maternal because of the mitochondria coming from the mitochondrial DNA coming from the mom, but they can also have Mendelian inheritance because of the nuclear DNA, which can also lead to mitochondrial disorder. Now, coming to the diagnostic testing as a screen, I tend to do in these patients creatine kinase and aldolase. Now, creatine kinase and aldolase discrepancy, which means that the creatine kinase is high and aldolase is normal, can also give you the idea that it could be some autoimmune muscle disorder or myositis. Acyl-carnitine profile, as we discussed, amino acid profile, and urine organic acid can help us about the fatty acid oxidation disorder. Lactate levels, urine myoglobin levels can help us in terms of the rhabdomyolysis. Nerve conduction study and electromyography can guide us about the disorders where we are not really sure that there is a metabolic myopathy or not, but it could be just normal in patients with fatty acid oxidation disorder or metabolic myopathies as well. Exercise stress tests, also as part of the screening, can be done in these patients. Now, coming to the specific testing, as I said, if we have genetic testing that can guide us about the type of metabolic myopathy, but muscle biopsy can be done, which is more invasive. And I'm kind of not in favor of doing muscle biopsy because of the invasiveness, but rarely you end up doing muscle biopsy to do special stains to understand the type of metabolic myopathy. And to be more specific, biochemical or enzymatic testing can be done, especially when the scenario is still confusing. So this is the flow chart or the diagram to whatever I have presented so far in terms of the evaluation and approach of metabolic myopathies or rhabdomyolysis cases that come to neuromuscular clinic. So initially CK followed by further testing based on how high the CK is. And you can run that an initial screening test, as we discussed. So management of these patients could be just like any neuromuscular condition or most of the neurological disorder is supportive care. There could be targeted treatment. If we know the mutation and the type of metabolic myopathy, genetic therapies are coming into market, which is very important. So there are more and more metabolic or neuromuscular conditions where there is a treatment available, or there are specific enzyme replacement therapies. Now, supportive care, as we discussed, could be lifestyle modifications. So they need to understand their exercise tolerance and work with the physical therapy and kind of go from there. So they may not have rhabdomyolysis, which could be a crisis, as it can lead to renal failure. Exercise schedule, nutritional modification could be very helpful in these patients based on the type of metabolic myopathy they have or metabolic disorder they have, like the use of carbohydrate before the exercise could be helpful. Vitamin B6 supplementation could be helpful in some cases. So cofactor treatment, accurate genetic counseling, because these are autosomal recessive disorders. So there has to be 25% chances of transmission in the next generation, and there has to be homozygous mutation to give the disease or cause disease in the patient. So accurate genetic counseling is very important. Sometimes you can ask for the genetic testing in the future spouse to help in terms of the transmission of the disease. Avoidance of the specific trigger factors like excessive exercise, sudden high intensity exercises, and how we can avoid it. Treatment of the rhabdomyolysis is very important if a patient lands into that crisis. Coming to Pompe disease, as I said, we're going to discuss a little more focus at the end of the discussion. So it's alpha glucosidase deficiency, what we call GSD type 2. There is a acid maltase deficiency is the other name for this one. So the incidence of GAA deficiency was noted to be 1 in 40,000. That was an old study in 1999, followed by newborn screening protocol over the time, which has evolved, especially in the United States. And what they have noticed, based on the initial screening at birth, is able to diagnose these patients early on. And the early and late onset form combined, the incidence could be 1 in 2,000, which is very important. So it's not as uncommon as we used to know before. There are more than 300 different type of mutations only in the GAA genes, and there are more of the variants involved. So there could be many different mutations, and naturally with those mutations, the variation of the phenotype could be there. There is a recommended uniform screening panel, which was implemented in 2015, and that involves testing all the newborns with the Pompe disease enzymatic analysis in the first year of their age. So there are types of disorder, as I said, there's an infantile form and there's an adult onset form. Adult onset form can further be divided into juvenile or adult form, but the manifestation or the clinical manifestation of these patients vary. The infantile form is naturally more severe. These patients tend to have cardiomegaly, respiratory distress, respiratory muscle weakness, feeding difficulty, failure to thrive, and the tongue may be enlarged along with hepatomegaly. In late onset form or the juvenile form, which is milder in terms of presentation, there's no cardiomyopathy, so they have a better life compared to the patients where it presents in the infantile age group. But there is a proximal muscle weakness, diaphragmatic involvement, camptocormia, which is the abnormal flexion of the spine, arteriopathy, carotid artery dissection, basilar artery, oligoectasia could be there, swallowing difficulty, gastroesophageal reflex, diarrhea, and constipation could be other manifestation of these patients. The workup, as we discussed for the genetic metabolic myopathies, so clinical histological features are variable, as we discussed, and makes it tougher to diagnose. And it can range from asymptomatic to severe progressive myopathy with typical histological features. Sniff test, which is a diaphragmatic movement assessment, or how much there is a diaphragmatic weakness. Pulmonary function test, sleep study can be done for the assessment of the diaphragm and sleep disorder breathing. CK-lactate dehydrogenase and liver enzymes can be done as part of the screen. Electromyography can give us characteristic myopathic discharges with abundant myotonic and complex repetitive discharges. But more importantly, as the Pompe is a glycogen storage disease, these patients tend to have cramps, and the cramps gives you electrical silence. In electrical silence, despite the patient has the cramp in the muscle and you can feel it on the physical assessment, but the needle in the muscle not going to give you any discharge. And that happens because those actin and myosin is unable to unlock because there is no energy production to release those arms from the myosin, and resulting in no muscle contraction which is noted on the electromyogram with no myopathic or muscle discharges. So in terms of the diagnosis, the GEA enzyme activity can be measured in the white blood cells or dried blood spot. It can be checked in other tissues, including skin fibroblast or muscles as well. Again, that is not very routinely done or done as part of the screening at the time of the birth of the babies. Next generation sequencing is the preferred test in the present time and era to confirm the diagnosis. But additionally, we do need genotype phenotype information on these patients to understand, do they really have the disease or not? Prenatal diagnosis is possible by DNA analysis or enzymatic activity in cultured amniocytes or chorionic villus sampling. So that could be one step to help patients who are probably going to have a baby and they're concerned about having Pompe disease in the baby. Histopathology, so there's a routine hematoxylin and L-sen staining, and that can give you glycogen storage vacuoles, which are lysosomes, and they are not able to eject out glycogen and just keep on storing it, and naturally that results in progressive cell damage. But more importantly, we can do the acid phosphatase stain and periodic acid schist stains in these patients, and they can give us the clue about the diagnosis. The differential diagnosis of glycogen storage disease or Pompe disease include fatty acid oxidation disorder, mitochondrial disorder, as we have heard already. Those are the other metabolic myopathies. But more importantly, these patients, we need to differentiate from spinal muscular atrophy. And there is a genetic treatment available for spinal muscular atrophy. There are limb girdle muscular dystrophies as well, which is another differential diagnosis. There is not treatment yet, but we hope that there's going to be treatment for muscular dystrophies in future as well, except for Duchenne muscular dystrophy, there is a genetic treatment available. So in present time and era, understanding the pathological process, confirming it is very, very helpful because of the targeted treatment therapies available in the market. Now, coming to the treatment for Pompe disease, so there was a treatment which was first used with the name of Myozyme in the European market, and it was introduced in 2006, which is an enzyme replacement therapy. Later on in 2010, it was also approved for the adult population as well. Initially, it was only for the pediatric population. There has been newer treatments over the time, especially in 2021. There's a new medicine came out which acts similar to L-glucosidase or Myozyme or Lumizyme, and it's called Nexviazyme. FDA approved it in 2021 to treat patients equal to or more than 1 year of age or patients with late onset Pompe disease. There's a standard dosing of 20 milligrams per kg, which is used intravenously every other week. There are new treatments available, especially in 2023. So there is another medicine which is recently approved in March of 2023. It's an enzyme replacement therapy, but additionally, they are also developing an enzyme stabilizer therapy with the name Miglustat. And it was approved in June of 2023, again in the European market. And the combination is considered to be a better option in terms of the long-term effect because of that enzymatic degradation. Naturally, it doesn't last longer, but with the help of the enzyme stabilizer therapy, we really hope that it's going to provide better muscle strength improvement and longer benefit of the therapy in these patients. So there are a couple of gene therapies which are not available yet, but in trials, they are still recruiting in some of those trials, but some has ended already and there's no result available yet. There is a substrate reduction therapy. In that case, we try to reduce the glycogen storage in the lysosome or in the cell. Those are a couple of therapies, but again, those are not in market yet. Those are also part of the trial. Chaperone therapies are small molecules which tend to attach themselves to the misfolded L-glucosidase enzymes and also result in some improvement or are suspected to help us in terms of the misfolding of the protein and help us in degradation of the enzymes. There is a stimulation of the lysosomal exocytosis, so the lysosomes who are already having enough glycogen in them they're not able to remove it, and resulting in progressive damage. So there are therapies being targeted which can result in exocytosis of the glycogen so those lysosomes can function properly and not result in cell damage. At the end, I'll say it's a teamwork between a primary care doctor, a nurse practitioner, or a physician assistant or primary neurologist. If they're gonna come across a patient where they suspect there is a progressive weakness or there's a chances of metabolic myopathies, they should refer these patients quickly to the neuromuscular physician and geneticist for further evaluation, as there are targeted treatment available once the patient is diagnosed. So beside the targeted therapies we discussed, we need a multidisciplinary approach by the PM&R colleagues, cardiology, pulmonology, orthopedic, nutrition, and physical therapies, occupational and speech therapy team to work together to provide the quality of care these patients really deserve. In terms of the prognosis, disease severity is related to the disease duration rather than the age. And the hours of the wheelchair use and a respiratory support increased by 13 and 8% respectively for every additional year since diagnosis. So it's very important to diagnose these patients early on and get them on the targeted treatment so we can have those, and not only they progressively decline otherwise, but to provide them with the quality of life, we should be able to provide them with a recent era of all the advancement. Now, talking about the genetics and precision medicine, so there is a terminology very commonly we use about variant of uncertain significance. When we come across genetic testing result, many times there are variants that come up as VUS. And what does that mean is that those are not yet to be decided whether those are benign or those are pathological. With more data over the time, it will become clear. And additionally, we can do what we call cascade screening, which is understanding the inheritance pattern and phenotype of the patient and the family, and seeing other family members in the family who may be having the similar phenotype or phenotypic features, and that help us in terms of understanding who could be another potential candidate to do the genetic testing. Now, coming to the family segregation analysis, which is a statistical analysis done by my genetics team to understand again and correlate these patients who can potentially have the mutation or a pathological mutation in the family. Compound heterozygous status is a terminology commonly used in our patient population where there's a not consanguinity. These patients tend to have more disease, especially with the compound heterozygous mutation, and that can result in the phenotype of the disease. So to understand it better, a patient needs to have a homozygous mutation to cause the disease. And consanguinity can increase the risk of homozygous status or homozygous disorders in patients. But in society where there is not consanguinity or less consanguinity or intermarriages, there are pathological genetic disorders because of the compound heterozygous status of these patients. So we recently published a paper in American Journal of Medical Genetics and about the hereditary neuromuscular disorders in Pakistani population. So what we have noticed initially on our subset of 112 patients that 47% of the patients, 47 patients, which is close to 42%, were positive for pathological mutation. VUS was noticed in 53 or 47.3% of the patients, and 12 patients were having negative mutation, which was 10.7% of the patient population that we selected. But as we did the genotype-phenotype correlation, and also we looked through their inheritance pattern and did the statistical analysis by doing the family segregation analysis. And there was a couple of other genetic tools that American College of Medical Genetics and also ClinVar and multiple other tools were used to understand those variants of uncertain significance. And with all those, what we were able to get to in terms of the correlation and understand how many of these patients were actually having pathological mutation. So 12 of the patients were changed from the VUS group to the positive mutation or noted to have pathological mutation. So the positive cases were 59 at the end with all that analysis, concluding to 52.7% of the patients. Also, the negative cases jump up to from 12 to 18. So to understand what happened in the case that I presented in the start, I call it deciphering the code, because what happened in these patients, you have to take all those pieces of information, put them together, and try to see what exactly is going on. So Duchenne muscular dystrophy gene is noted as a VUS in this patient, which is an X-linked disorder. She was a female, so that doesn't qualify in her case. PLEG gene, also consistent with autosomal recessive. Skin condition and muscular dystrophy, she was never noted to have a skin condition, so that is out of question. TTN gene is associated with autosomal dominant tibial muscular dystrophy, which is a distal type, but what she was having was more of proximal weakness. So what I'm trying to tell you guys is that genotype-phenotype correlation, but what we were concluding to that this patient probably have compound heterozygous status. Again, we were not able to prove it because for that you need the family variant testing of the parents to have that information and understand that if it comes from there and kind of diagnose the patient. But then comes the next part, which is let's go over bits of the cases and finalize it. So history and examination of progressive proximal weakness in legs more than the arms over the time, high CPK levels and liver enzymes, EMG evidence of degeneration changes in the proximal muscles, muscle biopsy with evidence of rhabdomyolysis. So we have all these pieces of information. Some pathological variant, we were not sure whether those are compound heterozygous or not, along with the VUS on her genetic test. But then we had this slide to show you what we have in terms of her CPK and also liver enzymes over the year. But then I had a chance to confirm with the muscle biopsy that she already had before coming to my clinic. And that muscle biopsy on a lateral analysis confirmed that she had some glycogen in the lysosome consistent with the Pompe disease because she was having most probably compound heterozygous status, which we were not able to do the family variant testing. But based on the muscle biopsy, we finally nailed down this case. So there was one confounder in her case, if you remember, that she also has Hashimoto's thyroiditis. So I looked into the polymyositis in patients with Hashimoto's thyroiditis. So the occurrence of polymyositis in Hashimoto's thyroiditis is very rare and not well documented. There was a Korean report from 2013. 2% of the patients with inflammatory myopathy have thyroid autoimmunity. Autoimmune processes alter skeletal muscles independently of the function of the thyroid status. Immunoglobulin and muscle fibers were positive in 80% of the patients, and the fiber 2 type proportion can be normalized with the treatment. So this was all very important. Again, in her case, it doesn't qualify to be myositis because she was not having inflammatory infiltrate on the muscle biopsy, but there was evidence of rhabdomyolysis. So at the end, what I would like to say is early referral is the key for these patients. Metabolic myopathies are very rare. Systematic approach can help reach the diagnosis. Early referral can be helpful in early diagnosis and treatment. Genetic testing and treatment options are changing landscape of neuromuscular disorders, and teamwork is the key to quality medical care. Thank you very much.